Okay, this is going to be the shock chapter introduction. So, shock is hypoperfusion, low perfusion to the tissues. It's defined as inadequate cellular perfusion because those cells can't get blood to exchange oxygen, carbon dioxide, and other things. Any compromise in the perfusion is going to lead to your cells dying because they can't offload all the products of anaerobic metabolism. They can't take on oxygen. They're eventually all going to die. So in the early stages, the body maintains homeostasis, which means that it tries to keep the status quo as best it can, which is basically what homeostasis is. So during shock, it can't transport carbon dioxide out of those tissues, so that's impaired. And what's going to happen are waste products are going to build up that cause cellular damage. Things like lactic acid is going to build up in your cells, and then that's going to cause them to break apart and die. So it's important in shock, which is poor tissue perfusion. It's a failure of the cardiovascular system, that you recognize the signs and symptoms early, and then rapidly treat and transport these patients. So just a general sort of picture to get on the cardiovascular system here, and this is usually how it's taught. It's sort of this like pump and pipes and fluid kind of analogy. So where the heart is the pump, then your blood vessels or your arteries, your veins, those are going to be your pipes, and then the blood is going to be the fluid content that's in. And you should know this just from our quizzes that we had, the blood flow through the heart. Now, what's important here is the perfusion triangle. So one of these things is going to be absent whenever someone is in shock. Either the heart's not going to be able to function correctly, so that pump isn't working anymore to actually get the fluid out to the tissues, or the blood vessels, the containers, the pipes themselves are going to be too large to actually pump all the blood because the pressure falls, or the blood itself, the contents of the fluid isn't going to be there for it, whether it's the red blood cells themselves or things like the plasma because you're so dehydrated from things like nausea, vomiting, diarrhea, other causes of non hypovolemic shock. All right, so pulse pressure is going to be an important vocab term here. That's going to be the difference between the systolic and diastolic pressures, but basically systolic pressure minus diastolic blood pressure. All right, it's going to be the amount of force the heart generates with each contraction. All right, the pulse pressure that's less than 25 millimeters of mercury, which is going to be basically the difference between the systolic and diastolic. If that number comes out to 25, less than 25, then those patients are in shock. Now, another important sort of formula to know is going to be your mean arterial pressure. All right, that's going to be the pressure during one cycle, whereas the pulse pressure is with each contraction. So your mean arterial pressure is going to be basically 1/3 of your pulse pressure. So systolic minus diastolic times 1/3. All right, plus your diastolic is going to be your mean arterial pressure, and that's going to be basically the pressure at that your body's going to use to actually perfuse the tissues. You want to keep that above 65, or even better, above 70. So we've talked about shunting before, where your body will shunt the blood from your extremities into your core, into your chest, for your heart, for your brain. The way this happens, or is the blood flow through the capillaries are regulated by circular muscles that they call capillary sphincters. So you can see here coming off the artery here, these capillary sphincters, they have precapillary and postcapillary sphincters that control this blood flow through the capillary. Now, your body's doing this all the time to determine the appropriate pressure that your body needs to perfuse the tissues. So it's not going to be under your control. It's going to be something that you don't have to think about doing. And it does this based on what the cell really needs. Now, some of the things the cell needs, one's going to be oxygen. So that's exchanged in the lungs. You have to pump that oxygen through your body. And then the nutrients in the blood, such as the glucose, which is going to be the most important, along with the oxygen, is going to allow you to create ATP, which is adenosine triphosphate. It's what your body uses to make energy, and it uses it for energy. and then removing any waste products that your cells actually produce. So things like that lactic acid that we talked about, and the carbon dioxide. The carbon dioxide is filtered and expelled from the body through the lungs. Now, when your body goes into shock, your body can actually sort of compensate for a limited amount of time for your body going into shock for that poor tissue perfusion. And that's primarily controlled by the autonomic nervous system and the hormones. Primarily, it's going to be epinephrine and norepinephrine. What that's going to do is going to increase your heart rate, because these are fight or flight hormones. So if you remember from our discussion about cardiac output, all right, so cardiac output is stroke volume times heart rate. So this is the output from your heart, from your left ventricle into circulation in 1 minute. So if you, say, lose amount of blood, right, your stroke volume is going to go down because you don't have as much blood anymore. So to maintain cardiac output, what's going to happen is your heart's going to start beating faster. So to make up for the lower amount of stroke volume, it needs to increase the heart rate. And the primary way it does that is from epinephrine and norepinephrine. It also causes those precapillary, postcapillary sphincters, your arterial smooth muscles, to actually constrict and increase the pressure. And the way it does that is your body's going to sense the fall in pressure. Now, like I said before, you have baroreceptors, pressure receptors in your aortic arch, in places like your carotid arteries, that can actually sense when your blood pressure falls too low. All right, and that's going to increase your heart rate because of things like the norepinephrine. Okay, and your epinephrine, it's going to also increase the strength that the heart actually contracts in. And then it's going to increase that peripheral vasoconstricting. So your peripheral arteries are going to actually constrict so that there's more pressure in those tubes and those pipes. Your heart's going to pump harder so that it can actually increase the output, and then your heart rate's going to go up, just like what we just talked about with cardiac output, stroke volume times heart rate. Now, this response from all these hormones and the things that are happening, they're going to be what cause the signs and symptoms of shock. So 3 basic causes of shock, right? If you just think on it on a really macro level, just simplified down, it's going to be a failure of your heart, a pump problem. It's going to be poor vessel function, which is going to be a problem in your pipes. They're going to get too large to maintain a decent pressure. Or it's going to be something like a low fluid volume actually in your system, so that there's actually nothing to pump. And this is sort of the same idea. So a pump failure, things like heart attacks, trauma to the heart that causes bruising to the heart, myocardial contusions, low fluid volume, like if you lose a lot of blood, hypovolemic shock. Fluid loss can also happen from things, like I said, like nausea, vomiting, diarrhea. It can actually cause you to lose a lot of fluid. So it's not as big a problem in the United States, where we have clean drinking water, but one of the leading causes of pediatric deaths around the world is going to actually just be diarrhea. Now, another thing that can happen is poor vessel function. Things like infection or narcotics can cause this. Spinal cord injuries, we'll talk about all this. So you need to know this. So there's 4 main, causes of shock. All right. 3 main. That pump failure that we talked about, the vessel function, and the low fluid volume. So we've gone over that. But you need to know all the types of shock. Okay, these are the general types of shock. One is going to be cardiogenic, which is going to be that heart problem. Obstructive is also going to be a pump problem. Like I said, we'll talk about all these, including tension pneumothoraces, cardiac tamponade, and PEs, pulmonary embolism. And then the poor vessels function is going to be what's called distributive shock. So there's going to be 4 main ones there: septic, neurogenic, anaphylactic, psychogenic, and then hypovolemic. So it's either going to be hemorrhagic, where you lose blood, or non-hemorrhagic on the hypovolemic. So you're going to need to know the categories of shock, which is going to be cardiogenic, obstructive, distributive, hypovolemic, and then all the different kinds of shock that happen under them. So cardiogenic shock is going to be when the heart fails. Obstructive shock is when the heart is pushed on. Distributed shock is going to be that pipe problem where they get too large and the pressure can't be maintained. And then hypovolemic where there's a fluid problem. So cardiogenic shock. So it's going to be an inadequate function of the heart so that it can't pump out the actual blood. Okay. The major effect is going to be a backup into the pulmonary vessels. And it's going to cause a problem called pulmonary edema. So edema is just swelling generally. Pulmonary edema is going to be actually fluid inside the pulmonary vasculature, which can leak out actually into the lung tissue. So if you think about your blood flow from the heart, through the heart that we've been talking about, this is the reason why we talked about it. Because things like cardiogenic shock, and later we'll talk about congestive heart failure, and what happens if the left ventricle doesn't function. So think about that. Number one, it can't eject blood out into the body. But number two, all the blood that's behind the left ventricle is going to start backing up like it's a highway that's in a traffic jam. So if the left ventricle isn't working, it's going to back up into the left atrium and then into the pulmonary veins, right? And into pulmonary capillaries and pulmonary arteries. Now what's going to happen here is in these small vessels, these capillaries, inflammation can happen that can cause this as well. But the linkage between the cells there is going to expand a little bit just because they're under such high hydrostatic pressure, just fluid pressure pressing against the walls of those vessels. And then fluids is going to leak out, something we call third spacing, or, increase extracellular fluid, ECF. So all the intracellular fluid that's in there, think your plasma that's in your blood, is going to start leaking out into your actual pulmonary vasculature, into the lung tissue itself. And then this fluid is going to fill the alveoli, which is going to cause them not to work anymore because, as we talked about diffusion, it can only happen across a short distance. And all that fluid into the lungs, into the alveoli, causes the distance to expand. And now oxygen and carbon dioxide can't cross the short barrier. They got to go over a longer one, and it just can't happen. So the heart can't maintain enough output to actually meet the body's demand, which is what cardiogenic shock is. So cardiac output, like we said, stroke volume times heart rate depends on several things. The heart actually contracting, and then the amount of blood coming back into the heart, which is a term we call preload. So you have to have blood coming back into the heart for it to actually pump out eventually. And then you also need some resistance in the peripheral circulation. Basically, the amount of pressure that the heart pumps against, it needs some of that. We call that afterload. So preload is return to the heart of blood. Afterload is going to be the resistance that the heart is actually pumping again because of the peripheral circulation. So obstructive shock. You can think about this as sort of a strangling of the heart and the great vessels. The inferior superior vena cava, the aorta itself, is just being strangled from the inside of your own body. All right, and there's going to be three causes of this. Number one is going to be cardiac tamponade, and then a tension pneumothorax, and also a pulmonary embolism can actually cause obstructive shock. So cardiac tamponade is important to know. So there's a lining around the heart called the pericardium. So think about all these vessels here that are on the outside of the heart. If your heart gets struck from something like, let's say blunt trauma, where your chest strikes the windshield and an MVC, what can happen is a pericardial sac will tear, but those vessels can leak out blood, leak out fluid, and actually fill up that sac around the heart. And if you think about it, the heart has to contract, but that means it also has to relax. Diastole has to occur, so it has to relax to fill up back up with blood. But if it's being strangled in its own, pericardial sac, it can't adequately expand out during diastole. So not a lot of blood is going to be able to fill it. It's literally going to be strangled, along with things like your pulmonary trunk here, as you see in this picture. So that sac is going to fill up with blood, and it literally compresses the heart. It's a serious medical emergency that the doctor has to take care of. So just the filling up of fluid into this pericardial sac is called pericardial effusion, like it says in this slide. Now, when it starts to constrict the heart, and cause it not to be able to actually pump effectively enough to actually perfuse the tissues. Call that cardiac tamponade. And the signs and symptoms of cardiac tamponade you're going to have to know. So it's called Beck's triad, all right, or Beck's sign. All right. Number one is going to be hypotension. And the thing you're really going to see with this hypotension is a decreased pulse pressure. So because diastole can occur normally, what's going to happen is the systolic and diastolic blood pressures are going to come closer and closer together. And when they reach zero, you can't pump anything out, basically. Now, something else that's going to happen is a constriction of your vena cava. And that means that what's going to happen is if you constrict that vena cava, you're going to get poor preload, blood return back to the heart. And blood's going to start backing up here as well. Now, where's it going to back up to? Because it's returning back to the heart, it's going to back up to where it comes from. So places like the superior vena cava, where it's going to come from, are your jugular veins. So that's going to cause those to be distended on both sides of your neck. It's called JVD. The last thing you're going to notice is muffled heart sounds. Right? So that's Beck's triad. You have to know all three of those. So attention pneumo is going to be the next obstructive shock cause that we're going to study here. So as you see in the picture, what's basically going to happen is there's going to be damage to the lung tissue. Think about maybe like a hole poked into the lung that's going to fill or leak air into the chest cavity in that pleural space, that lining of the lung. And what's going to happen is because air takes up space, it's going to push everything to one side. So what's going to happen is air is going to fill up to the lung. It's going to push everything. It's going to obstruct things like your aorta, your vena cava, and your heart itself. And it's going to push everything over. Now, in our trauma assessments, we said, hey, make sure you look for tracheal deviation. So what happens here, as you can see, this guy's trachea is starting to become deviated. Everything gets pushed over, so the trachea is going to be deviated to the normal side. And as everything gets pushed over, your lung collapse. Okay. In this case, the right lung here is going to collapse. It's going to press into the heart and squeeze everything into your mediastinum, which is this area basically in between, like just below your sternum is going to be your great vessels, your trachea, your esophagus, your heart itself. And it's going to constrict. It's literally almost going to strangle the heart itself so it can't pump. Now, because everything's being strangled here, including your vena cava, right, you're going to have JVD here as well. Okay. But you're also, because you're going to have that poor preload, you're not going to have blood returning to the heart. It's going to be much more higher pressures in the aorta because it's being constricted, that the heart has to pump again, and then the heart itself is just being strangled. All right, a pulmonary embolism, think of it like a blood clot. Okay, it's going to be a blood clot that blocks the vasculature of the lung. So it's not in the lung tissue itself. Primarily it's going to be in the artery, your pulmonary arteries. Okay. Now, what we have pictured here is called a saddle embolus. So, coming off the right ventricle here, you're going to come through the pulmonic semilunar valve, and this little branch here, this giant branch, is going to be called your pulmonary trunk. If you get a blood clot here, so no blood can actually flow through into your actual vasculature of your lungs, your pulmonary arteries, your pulmonary veins. Think about what's going to happen. So you may have blood that comes back to the heart, but no blood can actually get into the lungs, come back to your left ventricle here. So your left ventricle is going to be trying to pump, but no blood is actually coming back through. And that's called a massive pulmonary embolism, so what we call a saddle embolus here. So this clot is literally obstructing blood return to your left ventricle, which is why it's going to be an obstructive shock. All right, so a new category here is going to be distributive shock. So there are several things under distributive shock, but they all have the same basic causation or outcome. So it's going to be a widespread dilation of all your small arterioles, all your small venules, and they're all going to dilate. What that means is pressure is going to fall, because it's the same thing as when you put your finger over the hose, the water hose at home. Pressure goes up and the water comes out more forcefully, but if you let it go, that container basically gets bigger because you're moving the obstruction there. And then the actual hydrostatic pressure drops. And it's the same thing in your cardiovascular system. So all your blood is going to pool in all that expanded space. because there's not as much pressure, there's not as much afterload here. And that means that your tissue perfusion is going to decrease. So one of the types of septic shock or distributed shock is going to be septic shock. Okay, it's going to be a result of a severe infection. All right, usually what happens is you have bacteria in your system. It's usually bacterial, and those bacteria will release toxins. Okay, those toxins will actually damage those vessel walls and increase cellular permeability because it's an infection and it's going to cause inflammation. Now, the inflammation means that the space between the actual cells is going to expand in your vasculature, and that's going to lead to fluid leakage out of your intravascular space. Okay, and it's going to leak into the extracellular space. All right, it's going to leak out of your intracellular space into your extracellular space. And it's going to lead to extracellular fluid, ECF. And as a result of these toxins, your vessel walls themselves start leaking, and they can't contract well. They can't constrict to cause that fluid to stay where it needs to. So this massive loss of fluid from your blood plasma, okay, will actually result in shock. Now, one of the types of distributed shock is going to be neurogenic shock. So it's generally a high spinal cord injury. Okay, so think about someone's in a motor vehicle accident, and they have a spinal cord injury where the spinal cord gets torn in half, something. So all nerve impulses below that area of injury is going to cause your blood vessels to dilate, because the nervous system is what causes the signal to be sent to your vessels to actually constrict. So because it's autonomic, it's carried on the nervous system. You don't think about it, but it's happening all the time. And now, because those nervous system actually connections are severed basically from the brain, you can't actually constrict the way you need to constrict, and everything starts to pull. It becomes distributive shock. All those nerve impulses will cause, like the loss of them, will cause all those blood vessels to dilate and the blood to flow. And one thing about neurogenic shock you need to know, it's going to be a little different than some of the other types of shock. You're usually not going to have an increased heart rate because the epinephrine can't work because the nervous system isn't functioning. So everything below that area of injury, that's another reason they all dilate. You may also not have the same skin signs as other types of shock where they have things like sweating. You may not have that. So another form of distributed shock is going to be anaphylactic shock or just anaphylaxis. All right. Because what happens is it's a systemic allergic reaction where a substance enters the body and the body sort of overreacts on something that has been sensitized to, an allergen. So it can start off with sort of minor allergic reactions, but it can become more severe as your body becomes more sensitized to it. And what's going to happen is those allergens cause your body to release certain chemicals into your system, which causes everything to dilate. So things like if you've ever twisted your ankle and it started swelling up, that's an inflammatory reaction, and it was just around your ankle. But in anaphylaxis, that reaction of inflammation is throughout your entire body, so everything starts to swell up. So here's another important table that you should really memorize, because there's several signs and symptoms of anaphylaxis. Now, number one, the thing you're going to notice just when you look at someone is they're generally going to have hives, something we call urticaria. All right, those are itchy welts, basically all over their skin. So they're going to be flushed and very itchy. They're going to be really red. They're going to have a lot of edema, which is just swelling, especially around the face, the tongues, the lips. So it's going to be really hard to do things like ventilate the patient, even with the BVM. All right. They might have some pallor. And then as everything starts to swell up around their throat, around their mouth, their tongue, things like that, they're going to have poor oxygen exchange because they're not getting it into their lungs. So you can also see cyanosis. One of the first places you're going to see cyanosis is generally around the lips. Be the first place I check most of the time. So they're going to have a drop in blood pressure because of this reaction, because all their vessels are dilating from your body system reaction. So they're going to have a weak pulse if it's palpable at all. Now, they could have sneezing or itching, yes, but stridor is going to be the main thing. It's an upper airway sound because of all that inflammation, all that edema that's going to be in their upper airway. We've gone over stridor before. So it could lead to also an upper airway obstruction just from your own body tissue and all the inflammation, all the swelling that's there. They're going to have wheezing and dyspnea, so not only upper airway sounds that are bad, but lower airway sounds that are bad as well. And massive secretions in their bronchial passages, absolutely. And then some other minor things that you might not think of, but things like nausea and vomiting. If someone vomits and they have a lot of edema, they might just inhale that as well. And that's going to cause poor gas exchange as well because they're going to vomit contents into their lung. And when their blood pressure falls, they're going to start having altered mental status, dizziness, syncope, which is fainting, and then eventually coma. And because they have such poor oxygenation, it's going to lead to cardiopulmonary arrest. All right, psychogenic shock is going to be another type of distributed shock. This one's generally not as severe as other things. It's going to be a sudden reaction. It's generally a non-life threatening event. Things like bad news, right? Fears, where people just faint, or maybe they have seen blood and things like that. So fainting is syncope, so they're going to have syncope. But the thing you're going to have to remember is that if they have syncope and they fall, they could hurt themselves with other trauma as well. So syncope causes them to fall. And there are some life-threatening causes to this as well, including things like brain aneurysm, and which is going to be an outpouching, a swelling of an actual artery, and then irregular heartbeats can do it as well. Next is going to be hypovolemic shock. So hypo, low, and then volume, volemic shock. So it's going to be an inadequate volume of fluid, generally blood, in the circulatory system. So it can be either hemorrhagic, which is blood loss, or non-hemorrhagic, and it can occur with severe burns. Because if you think about it, your skin will actually keep in a lot of that fluid, not allow it to escape. And so people with severe burns can also have hypovolemic shock. And shock's going to have basically three stages. Number one is going to be compensated when your body tries to maintain that homeostasis, that normal business of things that are going on as best it can, with things like increased respirations, increases your heart rate, so tachypnea, tachycardia is going to try and compensate for things like blood loss. And then decompensated when your body can't maintain that homeostasis anymore because things like the byproducts are starting to build up, things like lactic acid are building up. So the last one is going to be irreversible shock, and there's no way to really assess when it becomes reversible or irreversible. So what you need to do is recognize and treat shock early. So by the time they get hypotensive, or where they have low blood pressure, they're already in decompensated shock. So another good table to know. These are going to be the signs and symptoms between compensated and decompensated shock. So one of the things that you should actually really look for are things like anxiety, which can seem like it's going to be a mild sort of reaction. You know, someone's been in a car crash. They've just been in a car crash. You would expect them to be really hyper and anxious because there's going to be a lot of epinephrine release. So they're going to be shaky, things like that. They're going to be restless. But when people start saying things like they feel like they're going to die, I always tell people I generally, believe them because they've been right most of the time. This is called a sense of impending doom. They will tell you that they feel like they're going to die. In compensated shock, they might have a weak and rapid pulse. It's generally going to be rapid. They're going to have cool, clammy skin, which is going to be like aphoretic, sweaty skin that's also feels cool to the touch. All right, and then rapid breathing, like we talked about before. Nausea, vomiting is very common. Because of the poor circulation, they're going to have an increased capillary refill that's greater than 2 seconds. Especially in infants and children, they're great people to check capillary refill on. They're going to complain about being thirsty because they're losing volume generally. And then they're going to have a narrowing pulse pressure. Now, in compensated, the first thing you're going to see is going to be a low blood pressure. So generally, it's going to be one that's going to be below 90 millimeters mercury systolic in adults. They're going to have declining mental status, altered mental status because of the low blood pressure. They're going to have labored or irregular breathing. At this time, their skin can be ashen or mottled. So mottled is splotchy skin. It's going to be this picture that's on the right here, so you kind of know what it looks like. You've maybe seen people like this before, but in decompensated shock, when it's not normal form, it's going to be a bad sign. So you need to know the difference between compensated and decompensated shock. One of the earliest signs of compensated shock is going to just be increased respirations. So it's going to be important that you actually count those respirations. So a really important thing here, blood pressure may be the last measurable thing to actually change in shock. So you got to look for things before they actually have low blood pressure, hypotension, before you start acting. So by the time they actually get hypotension, the shock is well underway, especially in infants and children, because infants and children can actually compensate for longer periods of time. But when they start decompensating, they go downhill way faster. So when blood pressure starts to drop in pediatric patients, they're really close to death usually. So just expect shock in any of these kind of patients. Patients that have multiple severe fractures, especially multiple long bone fractures, think of things like bilateral femur fracture, pelvic fractures, or something like a femur and a humerus even. Abdominal chest injuries, definitely spinal injuries. People that have severe infections, especially people that have been sick with things like pneumonia and you get a call. And then now they're not even febrile anymore. They don't have a fever, but they're actually almost like hypothermic. Those people are generally have a poor prognosis. Major heart attacks, people that have anaphylaxis, just reactions that are major allergic reactions. These kind of people, you got to think about that they're gonna just expect them to be in shock. Now, again, the important thing here on the primary assessment, the increase in respiratory rate is often an early sign that shock is going to happen. Another thing is when they have a rapid pulse, when they're tachycardic, that suggests compensated shock and trauma. So the first thing you should do is identify life-threatening bleeding and treat it as soon as you can. So again, it's important to recognize the early signs of cardiogenic shock, people that are having chest pain that you think may be having a heart attack. Try and expect this so you can kind of not be behind the 8 ball when this sort of thing happens. So these patients, and we're going to talk about nitroglycerin later on when we talk about chest pain. These kind of patients that are hypotensive should not receive nitroglycerin. So just try and remember that. These patients normally have low blood pressure. They have weak pulses, irregular pulses where the pattern isn't consistent. You're going to have cyanosis because of the poor gas exchange in the lungs, anxiety and nausea, a lot of vomiting too. So give them high flow oxygen. They need to be BVM. Do that. Prompt rapid emergent transport. And generally, you won't need to meet ALS en route to the hospital. But if you think you may need them for things like airway control, go ahead and give them a call. It's not going to delay transport and actual arrival at the hospital. For tamponade, this is going to be mainly a doctor thing where they have to actually use ultrasound to put a needle just in the pericardial sac to relieve all that fluid. All right, so surgery is going to be the only definitive treatment. Give them high flow O2 and increase the cardiac output as best you can. Same with tension pneumos. High flow O2 is going to be your main treatment. If someone needs chest decompression, which is a paramedic skill, what's basically going to happen if you call a paramedic for someone that has a tension pneumo, right? What they're going to do is they're going to take a kind of a big needle, a 14 gauge, an adult needle, which is kind of big, and they're going to put it in their chest to actually relieve the air pressure and try and get that air out of their chest. Now, the definitive treatment is going to be at the hospital. They're actually going to put a tube in there, put it up to suction to try and uncollapse that lung. So as for ALS early, if it doesn't delay transport. All right, septic shock. They're going to have to be managed in the hospital. They might need to be on medicines to actually increase their blood pressure. All right, so make sure you use your standard precautions. Give them the high flow O2, BVM if you need. Make sure that these patients get blankets. All the patients that are in shock by a trauma also get blankets, and then notify the sepsis team. It's going to be several criteria for this, so you don't have to memorize this criteria, but this is the old school SIRS criteria. It's systemic inflammatory response syndrome criteria, so they don't necessarily have to be septic for this, but they just need to meet two of these criteria. So either a temperature above 38 degrees Celsius, which is going to be, I believe, 100.4 degrees Fahrenheit, so they have a fever, or it's going to be below 36 degrees Celsius, which is going to be 96.8 degrees Fahrenheit. All right, they're going to have a heart rate above of 90, respiratory rate above 20. Now, if they're in the hospital and you're doing a transport or something, you can look at their white blood cell count, and if it's above 12 or below 4,000, all right, that's going to be one of the criteria. But basically, all I want you to know here on this criteria, if you have someone that's been sick, they've had things like the flu, pneumonia, whatever it is, those sorts of diseases that have a temperature or a heart rate above 90 or breathing above 20 times a minute, if you take two of those and they have two of them, go ahead and tell the hospital that they do, and you can call a code sepsis there. So the important thing in neurogenic shock for your treatment is that they have a good airway. People that have high cervical fractures on their cervical spine can have airway problems because the nerve that innervates the diaphragm is called the phrenic nerve, actually comes out somewhere in the C3, the C5 area, which is why you need to know that those anatomical positions of the cervical spine. Make sure they get spinal immobilization. All right. Help them with the BVM if they need it. Give them a blanket. All right. Make sure that you're actually helping their circulation, things like lying supine. If they can actually tolerate it, they're going to be on a backboard anyway. And then rapid transport to the hospital to see if they can get the help they need to get whatever spinal function they can get back as early as possible. In anaphylaxis, and we'll talk about this, so generally we give them an EpiPen, and you'll need to know these doses eventually, so I'm going to put them on here. So basically the EpiPen dose is going to be what we call 1 to 1,000 epinephrine, so it's going to be 1 part epinephrine to 1,000 parts water, basically normal saline. So for adults, it's going to be, of the 1 to 1,000, it's going to be 0.3 milligrams in those EpiPens. And the pediatric EpiPen is going to be 0.15. It's going to be half the adult dose in milligrams. All right, promptly transport these patients. Make sure they have high flow, non-rebreather at least, O2, BVM if they need it. All right, and if you just get called for what you may think is a normal allergic reaction, those mild reactions can worsen suddenly, so be on the lookout for it. And then if it's not going to delay actually getting to the hospital, call for ALS backup. There are several drugs we can give them as well. So what generally happens in fainting or syncope, once the patient actually falls, they collapse and they actually go supine because they're on the ground. Circulation to the brain is restored, so they quickly regain consciousness. They don't have any sort of confusion generally when they actually get up from syncope, when they actually regain consciousness. So there's not some sort of weird long period where these patients are altered. All right. But psychogenic shock can worsen other types of reactions. And make sure after the syncope that you check for injuries. Usually a head to toe assessment is going to be like the normal for that. And if they're unable to walk after a fall, suspect something else is going on, transport these patients properly. In hypovolemic shock, make sure you control all external bleeding that you can, particularly arterial bleeds. Keep the patient warm. So in hypovolemic shock, they lose blood. So your body actually needs to clot. Like I said before, if the body isn't warm, it's not going to clot. So generally something around 95 degrees, it's what's going to impair blood clotting. So if it's less than 95 degrees outside, at the very least, and it's going to be less than 95 degrees in the back of that ambulance, all these patients are going to need a blanket even if it's 90 degrees outside. So make sure that you maintain that airway as well. BVM if you need to, high flow O2, transport rapidly. So in your older geriatric patients, basically, they have more serious complications. It's harder to actually come back and maintain homeostasis than younger patients. All right. But illness is not just a part of aging. Now, what's going to be important in these patients, a lot of them are going to be on what they call beta blocker medications. All right. That will actually mask the signs of shock. All right. So that's the important one to know. Now, all these medications, like the suffix on them, end in LOL. Okay, on all these beta blocker medications. So it's going to be things like labetalol. It ends in LOL. So if you remember from our discussion that we've had before about epinephrine or epinephrine, these things actually attach to receptors. Epinephrine does, called beta receptors. And these patients that are taking beta blockers are not going to be able to actually increase their heart rate, so they're not going to become tachycardic. So you can't just look for tachycardia as a sign for shock, particularly in older patients. All right, just to review questions here. The term shock is most accurately defined as what? So our basic definition that we gave was inadequate tissue perfusion. So the answer is going to be B. All right, anaphylactic shock is typically associated with what? So we talked about this before. It's either A or C, right? So A, urticaria is going to be hives, those welts throughout the body. So it can't be C because they're not going to be localized. So the answer is A. All right, signs of compensated shock include all the following except what? Restlessness or anxiety. We went over that. Full clammy skin. We went over that. A feeling of impending doom. Weak or absent peripheral pulses. So it's going to be D generally. So while they can have weak pulses, right, in compensated shock, it's not the most common. So it's generally going to be thready pulses. Okay, so weak or absent pulses is going to be the most correct answer here. When treating a trauma patient who's in shock, what's your lowest priority? What's your lowest priority in your trauma patients that's going to be treated for shock? Right. So what we're looking for here is going to be basically the answer is going to be distracting injuries. So if someone has, an ankle fracture, that's going to be our lowest priority for people that are in shock. So actually splinting that kind of stuff is going to be low priority for us because it's only going to delay like you exit the hospital. All right, potential causes of cardiogenic shock. All the following except which one? So inadequate heart function, disease of the muscle tissues, severe bacterial infection, or impaired electrical system. The electrical system is what causes your heart to actually contract. So the answer is going to be C. That's generally going to be a distributive shock, septic shock. So cardiogenic, it's not going to generally be a bacteria. A 60-year-old woman presents with a BP of 80/60, a pulse rate of 110, mottled skin, a temperature of 103.9. She's most likely experiencing what. So you should be asking yourself why they actually gave you a temperature here where they don't in almost every other question. And the only actual type of shock here that we talked about that actually involves a temperature is going to be septic shock. So the answer is A. So a patient with neurogenic shock would be least likely to present with what? So tachypnea, hypotension, tachycardia, and altered mental status. So don't forget, this is shock, so they're going to be hypotensive. So the answer is actually C. Neurogenic shock. The nerves that control the sympathetic nervous system are actually compromised. So they're generally not going to be tachycardic. And they're going to be altered because of the low blood pressure, and they're going to have low blood pressure. And then they can also be tachypnic as well. All right, a 22-year-old man was kicked numerous times in the abdomen, so we're worried about hypovolemic shock here. So during an assault, the abdomen is rigid because there's a lot of blood in there and tender because it hurts. So his heart rate is 120, his respirations are 30 a minute. So what do you think the problem is? Yeah. So the patient can have either A or B, okay? But the real cause of your problems here is going to be the loss of blood because maybe that happened. All right, a 33-year-old woman presents with a generalized rash. facial swelling, and hypotension after being stung by a hornet. So why would they tell you this? Because people are allergic to hornets, so our blood pressure is going to be low, heart rate's going to be up. All right. In addition to high flow O2, what do they need most? And like we said, it's going to be epinephrine. So give them that EpiPen. All right. All the following are potential causes of impaired tissue perfusion except which one. So the only thing that we didn't talk about is too many red blood cells. The answer is going to be A.